Welcome to the Breaking Burnout for Nurses podcast. I'm Bonnie Kitahata, your host, and we have Melanie Wolf back. Today she's going to talk about utilization review. So I was asking her, what exactly is utilization review? I mean, I can kind of get the idea from just the words of it, but why don't you go ahead and explain what it is for us non understanding people?
Thanks, Bonnie. Thanks for having me again on the podcast. I really appreciate this opportunity to be here also. Um, I try to keep it as simple as possible. I'll try to explain it as simply as I can. So,
Perfect.
so a utilization review nurse is someone who is reviewing cases all day. You're taking a case. Now, what does that mean? What case are you taking? So let's just say that, God forbid, Bonnie is admitted to the hospital with heart failure. Someone like me is going to review her case, Bonnie's case, and I'm going to look at all the clinical criteria involving the case. Like, what is her troponin level? What is her, how much Lasix are they giving her? I'm looking at all the interventions that are being provided to Bonnie. And I'm going to match it up with this criteria that we have and see if she meets the guidelines to even be in the hospital, either observation level of care, which I know a lot of you nurses know what OBS is,
Mhm.
or inpatient level of care. There's a big difference in money between OBS and inpatient as far as at the admission level and for insurance purposes and payment purposes. So what nurses do, utilization review nurses do, is they may have a maximum, a nice good number that I think is a um, acceptable number for nurses is 20 cases a shift for an 8-hour shift. So
Wow.
about
Sounds
20
big.
cases. So you really are moving, but when you've done it for a while, you see an NSTEMI, which we all know in the medical field, nurses know what an NSTEMI is, a myocardial infarction. And so a heart attack. And so we know, oh, this is probably going to be a slam dunk admission, right? If I know they've had an MSTEMI,
Mhm.
I can go, yep, they're inpatient, boom, on to the next case. Here's
Mhm.
the criteria, their troponins through the roof, and here you go, right? And the troponin are the cardiac enzymes that tell you, oh, gee, I think this person's had a heart attack. So I think most of you folks out there in the medical community know what that is, but I don't want to use a lot of nomenclature that no one knows what I'm talking about. But basically, utilization review nurses, usually this day and age, because of the wonderful thing called electronic health records, the EHR, can work from home. And it
Yeah.
is, most of us are 100% fully remote. And that's why so many nurses want to go into this arena. And so, how the heck do you go from bedside nursing to utilization review nursing?
Mhm.
So, hopefully, that kind of answers the question as far as what we do. We're reviewing the cases, we're plugging in the criteria and going, yep, they had this criteria. They were on 4 liters of oxygen. She had heart failure, Bonnie. And so, yes, we know she meets the criteria. So that's kind of what you're doing all day long. You're problem solving. So if you like to problem solve and use your brain and analyze, that's the job. That is a job that you might enjoy because that is such a huge part of it. You've got to take a lot of pieces of the puzzle and go, okay, how can I get this person to meet inpatient level of care? What can
Mhm.
I do? What do I need to look at? How can I take all the pieces of their clinical picture and put it together? So that's kind of what we're doing. And so, how do you go from bedside to nursing? So, my stepping stones, which it really was stepping stones. Now, some people can jump right in it from hospital case management. My path was, I was a bedside nurse. I was hired as a nurse case manager and I excelled at it because I just like being a case manager. I was really good at the discharge planning piece of it and the UR piece. Because everybody that hits that building, you've got to justify that hospital admission with a case review. You got to review the case, match it up to clinical criteria to make sure they actually meet and need to be in the building. That's your job as a case manager. When you have little case managers wearing normal clothes walking around, that are the DC planner. Who's that
Right.
person? They're
Right.
doing part of the jobs you are, part of it's discharge planning. And so, but for UR to get specifically into UR, I went into, so from hospital acute level of care, not tertiary, but acute. I went, they liked me enough, this one company that was a managed care company. So they have lots of managed care, and we could talk about that all day, but we won't because it's not fun to talk about. But basically, managed care, I got hired out of the hospital. They were like, we want this person. She's efficient. She knows what she's doing. Let's pull her. So I got pulled into this company, and I worked for a hospital group, physician hospital group, that pulled me to manage their caseload. So it was
Mhm.
more complex case management with the tough cases, which, the ones that end up sitting in the building a long time, you can't discharge these people. Those are the complex case management, and also the utilization review piece. So we're doing case reviews on everybody. Do they need to be in the building? Using the criteria, not to throw too much words out at you, but interqual, if you've heard of interqual, Milliman care guidelines, those are the two gold standards for justifying hospital admissions with this criteria. So you literally check little boxes like Bonnie's admitted, God forbid, for heart failure. Yep, she's got 4 liters of oxygen. Yep, her chest x-ray looks this way. Yes, I'm looking at some of her cardiac enzymes. I'm looking at, her ejection fraction. I'm looking at all these things, right? And I'm checking boxes, literally checking boxes, and it turns green or it's red. And if it's red, you can't get them to meet. So that's what I was doing. So anyway, I worked for managed care, and then I was hired for a company that was a managed Medicaid company. So all of our patients were Medicaid, and we were the managing entity in the Bay Area. It's called Central California Alliance for Health. And so I worked for them, and I was hired as a utilization review RN. So I sat in front of a computer, and that's what you do. You are in front of a
Mhm.
computer. The only time you're dealing with people is when the director of the hospital case management department is calling you and saying, why is Joe still in the building? He should have been discharged already. So that's the time you're dealing with some of that. But most of the time, if you're strictly you're going to be sitting in front of the computer, and you're going to be processing cases all day long. And what's interesting, what you might like about it, these are the kind of the pros and cons. So the good points are like, oh, what's this case going to be? Oh, this person, what's she got going on? Oh, this is and the complex ones are when they have like 5 diagnoses, and you're like, I have no idea which diagnoses I'm going to use in the clinical criteria. Am I using heart failure? Am I using, what am I using here for this patient? So those are the problem solving skills that you use that are kind of like, ooh, that's kind of the, if you're analytical, you like to problem solve, that's kind of the fun part of it. And that's the part I liked and enjoyed about it, because I like using my mind. So I like that part of it. The parts that, and again, working from home in front of a computer during COVID was a very positive thing. I didn't have to mask up and do all this bedside stuff. So, and you wear your clothes and you're hanging out, so, but the cons, I will tell you, and I have worked for insurance. I worked for United Health Group. So I have
Mhm.
worked on both sides of it. I've worked for, so there's companies like McBee and Associates, which I worked for them for many years. And McBee and Associates actually are companies that are hired to go into different hospital systems, like in California, Dignity Health, for instance, to go into a hospital system. And we are going to review those cases with a fine tooth comb to save the hospital their funds, to say when insurance says, no, we're going to deny, we're going to say, oh no, Bonnie needed to be here. We've already justified this admission.
Mhm.
So that's that part of it. Now I work for United Health Group, which when you're working on the insurance side, they want you to deny as much as possible, obviously, so they can save their funds. And I mean, I hate to say that, but that's just
R-
how it is.
Right.
They're
Yeah.
they're looking to save money for their company. And so they also use criteria, the same criteria we're using for any company, which is the Interqual or the Milliman Care Guidelines. We happen to use Milliman Care Guidelines with United Health Group, but basically you're doing the same thing. The only difference is with insurance, you have a bigger caseload. I found to be like almost not reasonable, even like
Mhm.
to where it was like, oh my God, I was telling Bonnie, you pour your coffee at 7 a.m. and you're drinking it at 1 p.m. and you kind of forget you even have coffee sitting there because you are just like a machine trying
Yeah.
to process so many cases. And
Mhm.
so the cons can be, there's a hypervigilance mode that you kind of get in, like
Mhm.
you've got to get so many cases done, so you are being at the productivity level they're expecting you to be at. So
Mhm.
UHG actually had a thing set up on our computer where they could tell if you weren't working.
Oh my
So
goodness.
so you couldn't just go throw a load of laundry. It's not one of those jobs where, oh, I get to work from home. I'm gonna maybe,
Okay.
take care of my kid on the side, and I'm gonna,
Okay.
wash some clothes. And
Uh-huh.
it's not like that. Like when you're working, you
Uh-huh.
are in work mode. Like you are really working those 8 hours. You're
Uh-huh.
really like, it's not a job where
You
you're working.
can't throw in a load of laundry. Come on.
I mean, you can do it. Like, I'll tell you, you could breathe with McBee& Associates. I will say is a really great company. I had a positive experience with them. Very reasonable expectations of their nurses. And we had a good team and good leadership there. But UHG was different, it's a drive, and they
Mhm.
really push you. You have to present in front of a medical director, which we know is the physician, and it's a more high pressure that you feel with the insurance side, I
Mhm.
believe, and that's been my personal subjective experience. But everybody's different with that. Some people don't have that experience, so it just depends. But the cons can be the pressure that you feel to get the work done in a
Mhm.
certain length of time. You only have, and then if you get behind, let's say you get on one case and you get stuck on it and you just can't make this person meet no matter what you're doing.
Mhm.
And there's a whole process to it. You have to, if they don't meet, you've got to submit it to the medical director on duty, and they've got to come back with a determination, and you've
Mhm.
got to process it and put your little stamp of approval if they determine and deem that the patient needs to be in the building. So it's an
Uh-huh.
entire process that is just very time consuming. And you can get caught up on one case, it takes you an hour. And then
Mhm.
you get behind, like, oh my God, I've got to do how many more cases before the end of the shift is up. And so, but that's kind of the more the harder part is the amount of pressure that you might feel. But once you're doing it for a while, you get a flow with the job, and you just kind of know, okay, I'm going to need to bust out some easy cases right now. Let me find a heart attack. Let me find a
Let me find
I mean,
out.
it's terrible. We used to joke like, oh my God, a stroke patient. Yay, we
Yeah.
can just slam dunk the case.
Yeah.
But
Uh-huh.
if it's a stroke or if it's a heart attack, some cases you just know, if they've had a
Yeah.
STEMI, not even an INSTEMI, but a STEMI, they
Yeah.
are definitely admitted, no
Right.
problem.
Yeah.
So those you don't even have to work at all. That takes you 5 minutes to process that case. So,
Yeah.
but it just depends. And so, but I mean, I know you are really well. I know the world of you are. There's all different arenas. There's the insurance side, the non-insurance side, the folks that are
So
trying
it's
to.
the insurance side versus the hospital side, essentially, right?
Essentially, yes. It's
Uh-huh.
so the reason like McBee& Associates exist is we go in and we save the hospital systems millions of dollars because
Uh-huh.
they'll come back with a denial, the insurance company, and we'll say, oh no, they needed to
Mhm.
be here. And so
Mhm.
we justify like they had this or this
Mhm.
or this or
Uh-huh.
I'm and so that's why they hire us, because
Mhm.
we save them a lot of money. And so unfortunately that's just how it goes this day and age, is there is a lot of denial going on from the insurance side. But we have to try to keep their money because we want them to stay open. And certainly the small rural hospitals really struggle this day and age, as we know, if they cut the Medicaid funding, we
Mhm.
really will be in a world of hurt because the rural hospitals just can't stay open, because they're not getting money from anybody else. And as we know, I mean, most people that are admitted, I remember working in the hospital, and most of the cases I would see would be Medicare and Medicaid, Medicare and Medicaid, Medicare.
Mhm.
And there's a few people floating in with elective procedures, getting their knees replaced or something, that are from Cigna or some insurance company. But most people that are being served in the medical field are seniors and people
Mhm.
that maybe are indigent, or that are, that really have medical needs and maybe psychological needs as well. And so
Mhm.
that's what you see at a building. And so yeah, it was just interesting how we do a lot of, there's so much managed everything this day and age, managed
Mhm.
Medicare and managed Medicaid. But sometimes your head starts spinning because there's so many different insurance companies. There's so many. It's just, and then you throw in workman's comp, and then you just have a whole other. So anyway,
Oh, wow. Yeah.
yes. So, but utilization review is, if someone, and I also would also say, like, I'm very much a people person. I enjoy
Mhm.
teaching. I enjoy engaging with others. I sometimes miss case management in the hospital. And if you're an introverted type nurse, if you really just like, there's some nurses that are just so smart and so more into the, like, introverted, just their
Mhm.
personalities.
Uh-huh.
These are the kind of nurses that tend to excel. And you are,
Mhm.
because you're not talking to anybody for 8 hours. You are
Right.
literally working on a computer like this.
Mhm.
And so I tend to be like, wait a minute, I'm wasting some of my gifts. That's one of the reasons I don't do it anymore, is
Mhm.
my gifts lie in teaching and training and speaking and those things, instead of, and I can do it. And I did excel at it. And I was always a good UR nurse, but
Mhm.
there's people they really enjoy it. They can just sit in front of a computer and not talk for hours and be happy little campers. That would be the type of nurse that would be like, and the way you would get into it, just to bring it back to that, if you're in
Mhm.
bedside, you want to get into case management. And I
Okay.
know it's like, oh my God, discharge planning, I have to talk to people and do all these things.
Yeah.
But ultimately, if you don't have the case management experience,
Mhm.
you're not going to know what interqual is. You're not going to know what Milliman Care Guide. You've got to know what that criteria is. And
Mhm.
the only way to know that is to work as an inpatient case manager in a hospital, because
Okay,
that's
good to know.
that's where you process those
Mhm.
cases. You're
Mhm.
you're doing discharge planning. You're
Mhm.
discharging them and arranging the ambulance and the rest of it, but you're also, every single person that hits that building, you are doing a case review on them to make sure they need to be there, and you're using all of that criteria. And if you have that experience, a company like maybe an Associates will hire case managers at an inpatient or tertiary, acute or tertiary level of care, like a big,
Mhm.
big bad boy hospital like Stanford or UCSF or UCLA, any of those, obviously, but certainly any
Mhm.
community hospital that you work at, if you're a bedside nurse and you can get into case management,
Mhm. Mhm.
that's your stepping stone and will get you into a job where you can be, if you're looking for 100% fully remote gig in
Mhm.
nursing, that is how you do it. But you've got to know, when you go through that interview process, if you get to that place, you really got to know what interqual means, what it
Mhm.
is, and what MCG is. Otherwise, they're not even going to be able to, they're not going to hire you, because that's all the job is working with
Yeah.
that criteria day in and day out.
Mhm. So if you go the case manager route first and learn all about all that stuff, then you will have learned all that and be comfortable with it in order to get into utilization review, right?
That's right. That's right. And so, but again, I've worked with all kinds of case managers, and when I was a case manager, and there are those slow moving, very quiet case managers who really tend to excel more in the UR
Mhm.
section
Mhm.
versus me. I love people, and I was really more of a great discharge planner. I loved, sending grandma to the facility and arranging the ambulance and dealing with all the people and coordinating the care. I was a
Mhm.
huge, really good at coordination of care. And so it just depends on what your strengths are and what you're thinking, oh my God, I don't think I could sit in front of a computer for 8 hours. If you're that kind of nurse, because most nurses are people, they love people, they want to
Yeah.
be around people and serve. So,
Hmm.
but there are those nurses that are very, very smart and like to hang out in their, just really love to think and problem solve and analyze.
Hmm.
Usually the ICU is where I find those nurses that are just, and I'm saying all nurses, obviously we're all, intelligent and work very hard and learn and all of that. But there are those spots where they love, love, love analyzation. They love
Hmm.
learning the disease processes and like really get into it. And so, and that's what you're doing a lot with you're looking at the disease process, you're looking at,
Hmm.
what's, and you're having to kind of, and there's no guesswork in it. It's a very definitive game. It's either black and white. They either meet or they don't meet. And so, but yeah, it's a whole other beast of nursing that a lot of people are like, what exactly is you are? Because when I say utilization review, nobody has any idea what I'm talking about. It's
Yeah,
just,
most don't. And how do you get paid? Is it by the case, per case, or per hour, or how do you get paid usually?
yeah, it's usually, it depends on the company. Like usually, um, the insurance companies pay a salary per year, and they do that so
Oh, okay.
they can work you overtime, which we got to a
Yeah.
point we were like, no, 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 no,
Oh,
we're not working. I never worked more than 40, even though they were trying
uh-huh.
to push it because we were
Right.
quote unquote salaried.
Oh,
But
okay.
but with me being associates, it was hourly. So that
Yeah,
was nice
okay.
because you got paid by the hour.
Mm-hmm.
It's not going to be on the high end unless you really push for a higher wage. I
Mm-hmm.
mean, if you're a travel nurse, you're certainly going to make a lot more money, but
Mm-hmm.
it's very comparable to if you were doing bedside. You're not going to make so much more money. It's not going to be like, oh, I'm making, it's not so much more money than bedside
Mm-hmm.
nursing, but
Mm-hmm.
it's about the same really as far as that goes. I could definitely make more money as a travel nurse than being a nurse, but then it's nice because you're not dealing with patients if that's something that you kind of need a break from, or you're just
Mm-hmm.
like, I just really want to do something a little different, or but again, you got to get into case management at some level and know that job pretty well in order to go into the arena.
Well, thank you, Melanie. That
Yeah.
that was a lot of good information. A definite good alternative nursing option for the nurses out there who are looking for something a little different from the bedside nurse, or just to get out of whatever they're in right now. Sometimes
Yeah.
you just want to change, and
Yeah.
sometimes, yeah. So I think that's a great option for people.
And
So
Bonnie,
again, yes.
yeah, I was just going to say one last thing is like, and this, Bonnie, too, and I'm sure you tell lots of people, but as you've been a nurse a long time, I always tell
Mhm.
people try different things. If
Yes,
one thing
definitely.
doesn't work, go to the next thing. And like
Yeah.
you're in a field where you could go be a camp nurse somewhere. I mean,
Yes.
you could do a plethora of jobs as a nurse. So just,
Yes.
if it doesn't work in
You know,
one area, go to the next one.
one thing I want to remind everybody is, if you are trying to leave your job because you're so, uh, sick of wherever you are, burnt out, don't leave unless you first are taking care of yourself. Get the basics, like we were talking with a previous episode about, you know, um, the hydration, the sleep, the nutrition, the self care first before to make sure that the place that you're at isn't, isn't the problem that maybe it might be, because you're not taking care of yourself in the first place, that no matter where you go, you might be miserable. So take care of yourself first, and then consider utilization review. Right, Melanie?
Yeah, and I would also say, wherever you go, there you are. It's like you're bringing yourself to the
How
next
profound
job.
you are, Melanie.
So it's like wherever you go, if you're so again, like Bonnie's saying, take care of yourself and whatever. If you're a nurse, you also want to make sure you're hydrating and like
Yep.
pausing on the hour to say, hey, I'm going to breathe for a few minutes.
There you go.
And so
That
that's
breathing
super
is
important.
it's a good thing. All
Yep,
right.
that oxygen's a good thing.
All right, Melanie, tell us your website and your how we get in contact with you.
Yes, and so I have a program, and it's called Rooted and Regulated. You can find it on my website. It's regulatewithmelanie.com. Regulatewithmelanie.com. And the Rooted and Regulated program I designed was really for high productivity folks that are just feeling on the verge of burnout, maybe even dealing with chronic illness, to better regulate their nervous system so they can feel better in their lives day to day. And that's a 1 month nervous system program. And then I also do other things like public speaking. So if anyone is interested in, I do like to do nurse conferences and definitely speak in that capacity. So also do that as well.
Well, thank you, Melanie.
Yeah. Thanks,
All
Bonnie.
right. All right. So, nurses out there, if you, hey, how about this? If anybody out there wants to be a guest on my show, if they have some burnout story that they want to share and tell us how you dealt with it, then go to my website at breakingburnout.com and go to the podcast tab, and then learn about the podcast and sign up. Anyway, so everybody come back next Monday at 10 a.m. Pacific because we are breaking burnout here. Bye. Thank you, Melanie.
Thanks, Bonnie.